Hello and welcome. Today we bring you one of our faculty members who have published a recent paper from virus COVID-19 registry. Welcome, Dr. Erika Bjornstad.
Thank you so much, Rahul. So I am, as you said, a pediatric nephrologist from the University of Alabama at Birmingham, and had the pleasure really to work with the virus registry from the beginning and work with collaborators for this publication.
Thank you. Thank you so much for being here with us and for that introduction. You're one of our most productive investigators, and then you've been with us since the beginning, actually, in the registry. So my first question is, first of all, congratulations for publishing one of the landmark studies in BMC nephrology, looking at SARS-CoV-2 infection and acute kidney injury, not just in the pediatric, but adult population. So tell us about what are the results coming out? What are the highlights of the results for general public or researcher or clinicians who are interested in this space?
Great, thank you so much. Yeah, the title really gives away the punchline of what we found, but I want to back it up a little of why we looked at this question. And our question really was, among all of the patients getting hospitalized with SARS-CoV-2, why were older adults seeing such higher rates of acute kidney injury? Meaning, we in the pediatric world saw adult hospitals using up dialysis resources for kidney failure at much higher rates than we were seeing in the pediatric population. And what we found surprised us. We came into it with the question of, let's just describe the age distribution of those who get acute kidney injury. And we expected to see a kind of linear increase in acute kidney injury across the age spectrum. What we found is that there was this bimodal distribution, meaning there was a peak of acute kidney injury in 10 to 15-year-olds, early childhood, that went down amongst the young adults, but then it rose linearly across the age spectrum. As you would see, if you just looked at the adult population, acute kidney injury rises with increasing age. If you just looked at the pediatric population, there's this weird peak in adolescents and early adolescents, but then it's probably just because we don't have enough sample. But what virus allowed is they include not only adult critically ill patients, but pediatric critically ill patients. So we could really look at this across the spectrum and we could compare what was going on. And it surprised us. Why is this? And we looked at, well, maybe it's severity of illness. That didn't factor in. Maybe it was location, right? Even though this is a large international registry, the majority were in the US, but a third of our centers that we included were outside of the US. And if we looked at only US or non-US centers, that distribution still remained. We looked at those with comorbid conditions, whether there's diabetes or hypertension. And if you removed all patients with comorbid conditions, the distribution was still the same. Why does a 10 to 15-year-old still have the same risk of acute kidney injury as a 70-year-old? It just doesn't quite make sense. So what we learned from that and kind of going forward is there's something unique within the SARS virus that is contributing to this, and it can't be just explained by severity of illness. I think the majority of you all know, as clinicians and researchers, there's a high risk of acute kidney injury in patients hospitalized with SARS-CoV-2. We saw that same thing in our paper. 40% of those hospitalized had acute kidney injury. If you have acute kidney injury, it increases your risk, sometimes 2, 3, 4 folds higher than those without acute kidney injury. But something else is going on. And I think that's really what needs further exploration. And we need to dig into that a little deeper. We know from other organs affected that SARS is really attacking the endothelium. And there's this portion of patients with kidney injury that we need to explore that is beyond just your normal risk factors for kidney injury.
Absolutely, such an important finding as you're explaining it. And then, I don't think so the virus COVID-19 registry is equipped to look into further why that is happening. What's your thoughts as a clinician, as a scientist yourself, and having a double doctorate degree, MD, PhD, what do you think would be a reason why that is happening, why you see what you saw?
Yeah, I think the bulk of kidney injury is from common causes, right? They come in super sick, so they have a low volume, low blood volume, and so they're not perfusing their kidneys, and that is causing kidney injury. They're really sick, and then we throw nephrotoxic agents or drugs that harm the kidney on top of that because we need that to save their lives. We expect that in nephrology, but there seems to be this portion with high levels of protein in their urine, high levels of blood in their urine. And there's a lot of data in the kidney world that SARS itself may impact the kidney itself. I think that question remains to be answered, but I think we need to look at that in more in depth. We need more pathology studies, looking at the kidney tissue itself. We need more animal-based studies looking at this so that we can then translate to that to the clinical side and see what we're seeing. I think virus, even though the data collected at the virus level registry might not be able to answer that question, it moves us further in that question and explores that further. It also allows for collaborations and connections that might not have existed amongst clinical researchers, right? Maybe we need to be partnering with our endocrine colleagues for why in the puberty stage, they have a similar risk profile as our older elderly patients for having acute kidney injury. And so I think combination of translational research and in-depth clinical research is needed to start to figure out why this is going on. And then that can help us down the line with therapeutic targets or prevention methods that we need going further.
Rightly said. Well, publishing landmark studies such as, were you able to compare your results with existing literature at that time? If so, how similar they were or how different they were? And you said that you were surprised to find this bimodal distribution of two different types of times where the risk is higher. So any insights on that part in comparing your study results with the existing literature at the time?
Yeah, so definitely. And I think even since then, more has been published that there are extremely high rates of acute kidney injury. That I think is well accepted and well known. And what is less clear is, as I suggest this hypothesis, that it's the endothelium effects of SARS-CoV-2. And there are at least a couple other papers out there that have found the risk of acute kidney injury is occurring outside of our common risk factors. And that's what's puzzling. And that's where the theory of the endothelium effects on the kidney are occurring. However, I think ours is one of the only papers I have seen out there that looks at kidney injury across the age spectrum. Those tend to be only adults, only pediatrics. If they look across the age spectrum, they might be in a cancer cohort that goes from pediatric to adult population. But what we were able to do is look at a general hospitalized population, both ICU and non-ICU patients. And so I think we take that question further, that this really deserves further investigation because we were able to see this across the age spectrum. I think that bimodal distribution would have been missed if you weren't able to compare pediatric and adult populations in the same cohort.
Well said, well said. I'm going to switch gears and ask you,
Yeah.
So a journey of a pediatric nephrologist from Alabama and then collaborating with virus COVID-19 registry, SCCM Discovery part and other investigators. How you got connected? I understand that it's COVID time, and then we can't do much with our own institution data when it was only 50 or 100 patients and so on and so forth. So how you got connected, as well as what has been your experience so far?
Yeah, so as you mentioned earlier, I'm also wear a different hat as an epidemiologist. And so one of my areas of interest is using larger databases to ask the big questions. I think these allow us to ask big questions that we can ask smaller questions with our individual institutions. In pediatrics, we are used to collaborating across institutions. Pediatrics is not thankfully, we don't see the high burden of disease that adults do in the internal medicine world. And so that kind of allowed for that from the beginning. I can't recall the details exactly, but the virus registry kind of came across my email and I was interested and jumped on board, and they were super inviting and welcoming and really collaborating from the beginning, and welcomed in a pediatric nephrologist to the SCCM collaborative, which was wonderful. And it was great to kind of work along as we've built these collaborations going forward.
Perfect. So what next? You have published this, you wear so many hats, you epidemiology, MD, PhD, taking care of this sick kiddos and everything else. You have published this. What is your next project? What you're looking into expanding the work you have done so far?
Yeah, I think the next is asking those more detailed questions. Right now, we are asking a more detailed question of what can we learn from the virus registry so that we can capitalize on the data that's been collected, and do we need to be partnering maybe just with one or two institutions from within the virus network to ask more detailed questions of why do 10-year-olds have the same risk of kidney injury as 70-year-olds. Now, what we are unfortunately 2+ years into this pandemic, there's actually more in-depth data that can be gathered. More patients have had kidney injury. Unfortunately, we may have more biopsy data out there that we just don't know about. And I think that's my hope and my desire going forward. Certainly, I'll put a plug out there if someone has the energy and enthusiasm to help me look at this, especially on the adult side, would be more than happy to collaborate. And so we're just kind of getting into smaller nitty details of this question.
That is music to my ear. Collaboration, and absolutely, we can go a little bit more granular in the data, and then ask some more meaningful questions than what you've done. What would you advise? And probably this is my final question to you. What would you advise to the junior investigators who have not done these kind of collaboration, not being part of these kind of collaboration, and what would be their advice, your advice to them, how they can break these silos and how they can be benefited and contribute their knowledge, wisdom, and resources? What would be your advice?
Yeah, I think if there are junior investigators out there listening to this, I think certainly getting involved in the registry. I don't think it's too late to sign your institution up, to find out who at your institution might already be involved and already kind of has too many things on pots on the stove that they need someone else to kind of help carry the torch further. And if not, certainly just call Rahul up. He's great, right? But seriously, I think reaching out to the registry is one first way to get involved and find out there's always the need, and there's a good collaborative spirit within SCCM and within virus. And then, or if you have a more detailed question from your institution, I think the leadership team within virus can help connect you with people who might be more experienced to help guide you and mentor you along the way. I certainly would not be where I'm at without the mentors that I've had in the past helping me get to this point, and to not feel afraid to say, yep, I'm interested, sign me up.
Absolutely. No, I think mentoring is another one. It is so much underrated. We can never have enough mentoring, especially in healthcare field, in all spectrum of that. So last question, I've asked this unofficially to everybody I talk to them. Let me ask this officially. What does your crystal ball say about the COVID-19 pandemic? How you start seeing it? Is it going up again now? You start seeing a little bit more patients. I'm hoping that this should be ending soon so we can wrap up the registry and move on to other projects for the collaboration. What does your crystal ball say?
My hope, it says something different than I think what the crystal ball is portending for us, right? The data, if you look at CDC or others, is harder to compare from year to year because we've switched from looking at cases to looking at hospitalizations, which is appropriate from a public health perspective. That is what is devastating our hospitals. Even though I'm in the South, cases are climbing up. We're not seeing our hospitals devastated. So I think those are good metrics to follow. But unfortunately, what my crystal ball tells me is January 2022. So sorry, going back in my crystal ball, January 2022 was the worst of the pandemic for a pediatric hospital. I don't envision that January 2023 to be drastically different unless things change and we are okay to put masks back on in the fall when cases really start to rise. We have better vaccine uptake. And so until those things happen, I don't think winters going forward for the next few years will look much different.
No, absolutely.
I hope I'm wrong, but I think we are in for a long haul that the next few winters might as well keep the registry open.
Yeah, no, I hope so too. And especially now with at the time of recording this video, the recent advancement of approval of vaccines for younger kids, 6 months and to up to 4 or 5 years old, it should provide an extra layer of protection. Should happen extra layer of protection. Having myself one of those kids in that age range, I'm anxious to have him give the vaccine. He's the only one it's without the vaccine protection so far. Everybody else is. Well, thank you so much for your time this morning. Really, really appreciate you have been a cherished partner, a collaborator, a mentor, and taking on these projects. The group has learned from your expertise. I don't think so. We have that much trained epidemiologists, MD, PhD, pediatric nephrologist in the group or even close to that. So we always appreciate it. Many, many congratulations for your landmark publication. We hope to see many more come out from it or other project. We will keep an eye on it. We really appreciate you being here with us today.
Great. Thanks so much, Rahul.
Absolutely. And those who are watching it, please like, subscribe to the channel, write down in the comment section what you like, what you want to hear from Dr. Bjornstad, especially, how super specialist he is. We can bring her back to ask some specific questions in the clinical care what she provides. Thanks for watching.